Hello, everybody. My name's Ken Miller. I'm the clinical educator of respiratory care services, and I've worked in respiratory care about 48 years, and I've had a lot of experience with taking care of patients with asthma. One of the new, interesting, and very vogue type of therapies when we're dealing with the management of asthma is biological therapy and the use of biologics in severe asthma. Now, this is utilized for patients that have refractory asthma to conventional type of strategies. So today we're going to talk about, describe the prevalence of asthma, define refractory or what is severe asthma, describe the immunological responses in severe asthma, and then we'll talk about and review some of the different biological therapies currently available for the management of severe asthma. So let's talk about the prevalence of asthma. Asthma is a very common malady, and it affects a lot of people, both in the United States and worldwide. It affects approximately 300 million individuals worldwide, and it's associated with chronic airway inflammation, reversible airway flow, expiratory flow, and airway hyperresponsiveness. Now, it's very important to really stress here, and I think this is often lost with our asthmatic patient population, that even when the asthmatic does not have symptoms, they're not wheezing, they're not coughing, they're not short of breath, they still have asthma, and there's still inflammatory mediators being released, and there's constant inflammation causing the airways to possibly get remodeled. We talked about in one of the lectures thermoplasty, which is a therapy to try to get rid of that scar tissue, for lack of a better word, from the constant inflammation. So a lot of times these asthmatics don't realize that they are really symptomatic when they're asymptomatic. And reversible expiratory airflow really kind of relates to being able to be responsive to bronchodilator therapy. And then airway hyperresponsiveness is really associated with the airways being very sensitive to triggers. You, me, somebody else is in a room, there's a dust plume, one person might sneeze, one person might not even notice it, and then the third person, me, might go into severe bronchospasm because that's a trigger. So severe asthma is defined as, possibly poor adherence to inhaled corticosteroids. So you're talking about patients that either don't have very good response by using the anti-inflammatory diseases. Remember, looking at GINA and the National Panel of Respiratory Therapists, really the recommendation now is, as your single maintenance drug, to use an inhaled steroid. But this patient population, despite taking inhaled steroids, don't have very good response. Some of them have very poor inhaled technique, and they have continued exposure to triggers and other exposures. So, and the control remains poor despite addressing the above. So you look at a patient and you say, the patient comes to you and says, I'm doing this, and I'm still having the symptoms of asthma. I wake up wheezing. I can't perform daily tasks because I'm short of breath. And then you say, well, let me see you do your, are you taking your medicines? Let me see your technique. And have we got rid of the triggers that are known to cause your asthma to get worse or become symptomatic? If all those things are, kind of assessed and ratified in the sense that you remediate those and you basically say, okay, now the individual does do the inhaler right, the individual is taking their steroids, the individual now has got rid of the pets or been able to get rid of cockroaches and other type of, or they stay away from, the outside environment and they move from the city to the country or something like that. But despite that, they still have symptoms. So they've done everything correctly, but they continue to be symptomatic. So 10% of adults, so that's 1 out of 10, and 2.5%, so 2.5 children out of 100 are classified to have severe asthma. And this results in a reduction in the quality of life, increased healthcare utilization, missed work days or school days, increased hospitalization or death. So in this patient population, they're symptomatic almost every day. The symptoms cause them to miss work, be non-productive, or miss school, not being able to learn. And often this is a group of patients that visits the ED frequently, and unfortunately get hospitalized. And unfortunately, sometimes the mortality rate for asthma is very low. It's less than 0.5%. But the bottom line is that there is a lot of asthmatics, and this is the really high-risk group that could lead to mortality and increased morbidity. So these patients, as I said, have frequent exacerbations. Okay, they need repetitive oral steroid bursts. So typically, these individuals are classified when they need oral steroids more than 2 times a year. Less than 2 times, 2 times or less is considered to be still controlled asthma. But these individuals often need steroids every other month, maybe even a long duration of steroids, not a short burst, but an actual longer duration. They use a lot of LABAs and SABAs and inhaled steroids. They're on the Advair 550, plus they're using their rescue inhaler every 4 hours. And because they're using an auto medication, they have increased side effects. They have tremor, shakiness, tachycardia, increased chance of thrush because of all the inhaled corticosteroids they take in, and they can get Cushing's syndrome from the repeated use of oral steroids. So this group of individuals have a poor quality of life because they're often sick, they miss a lot of activities, and they have a lot of side effects from the increased amount of medication. So we look at this, the etiology of severe asthma, and we talk about something that's relatively new. I had done a lecture on some of the new trends in 2023 asthma, and one of the current ideologies with the management of asthma is looking at this heterogeneous biological individual specification, meaning that, yes, we can take all asthmatics and we can clump them into one group when it comes to certain symptoms and certain medications. But really, each asthmatic, when you break it down, especially with severe asthma, you have to treat these patients a little bit different, because when you look at them, they have a type 2 high inflammation, which is marked by increased eosinophilic airway inflammations. They have high levels of leukotriene-4s, which increase secretions of lymphocytes. Interleukins-5s promote proliferation, activation, and survival of the eosinophils. And then leukin-13 induces smooth muscle contraction and stimulates the nitric oxide synthesis in bronchial cells, which will cause bronchospasm. So when you look at patients that have severe asthma, you have to think about where, even though we treat asthmatics kind of all lumped into one, we have to figure out with this group, what exactly is the factor that's causing them to be refractory to conventional therapies. So we look at this is an inflammatory pathway, type 1, type 2, type 3. And you can see that, in type 2, that's your basophil and eosinophil type and the mast cell. So this is really the type 2 seems to be the refractory mediator form of asthma. And then when you look at the key cytokines, where are the interleukins being released and the mediators? IL-4, 5, 13, 31. Where you look at type 3 is more neutrophilic and type 1 is more macrophage. So it's this type 2 that seems to be more responsible for the refractory asthma. And you can see, you know, they cause neutralized toxins, regulate wound and repair, suppression of type 1. And that's kind of the function of these mediators in these cells. And then the examples of the consequence of deregulation associated disease. So you have to understand that a lot of these diseases are autoimmune. You look at psoriasis, you look at Crohn's disease, you look at rheumatoid arthritis, lupus. A lot of these are autoimmune systems. And we could argue in COVID, there was some belief that it was a cytokine storm that determined the outcome of the patient, not necessarily the severity of the actual variants of the COVID virus. And then you can see in this group where if you look at type 1, you know, that causes like diabetes, rheumatoid arthritis, sarcoidosis, you know, inflammatory bowel. So this is very common in a lot of patients. But now you look at here, this type 2, and that's what we focus on, is allergies, antiphylaxin, type 2 asthma, refractory, again, refractory COPD with inflammation, and then chronic rhinosinusitis with nasal polyps that usually need some kind of surgical intervention. And then we look at type 3, the neutrophilic, and we see things like psoriasis, multiple sclerosis, etc. So really the type 2 is where we're going to be focusing on, because that has, you know, these are the mediators that we need to block in order to, you know, take that as refractory asthmatic and give an increased their quality of life and try to make them asymptomatic. So again, the healthy airway is, you know, you look at, you know, the rhinovirus and you get this plasmodic dendrite cell, you actually have type 1 interferons that actually help prevent the airway from being infected and going to bronchospasm. So it's the absence of this type 2 inflammation and low circulating Ig, which is in the normal healthy individual that's not asthmatic. The asthmatic airway, there's the presence of these type 2 inflammation. There's a lot of immunoglobulin globulin E arming these cells. There's fewer interferons as protection, and then the airway becomes very, very susceptible. And you can see there's increased mucus secretion, bronchospasm, and then reduced airway lumen. So again, this is the difference between this healthy airway, the non-asthmatic patient, and the asthmatic airway. So we look at, again, focusing on type 2. Type 2 asthma, more severe asthma, a lot of airway and systemic eosinophilic type of. They do respond to corticosteroids and responsive to inhibitors of type 2 inflammation. Type 2 asthma, less severe. There's an absence of airway and systemic eosinophilic, lack of response to corticosteroids, and there's lack of response. Okay, so again, we're looking at this group that we can kind of control. Now, this is, I know, a busy slide, but try to give you an idea here what's going on with these interleukins. So you can see you get, you know, your triggers are up at the top here. You got viruses, microbes, allergens, whatever. This then causes this release of the dendrite cell to the Th17 cell, which will then cause, in this sense, interleukin 4, interleukin 13, which causes the B cell to cause mast cell release and histamine, okay? Now, in this cell, you get your type 2 cell, asthma. You get interleukin 5, and that causes an increase in eosinophils and also leukotriene release. And you can see where the neutrophilic release causes thickening of airway. You got hypertrophic of the airway smooth muscle secretion, fibroblast inflammation, infiltration, and proliferation, and that equals, you know, asthma, refractory asthma. So when you look at this, you know, when you're going to look at these biologicals, you're going to try to figure out what biological can block interleukin 23, what can block interleukin 5, 4, 9, 13, 4, etc. Here's interleukin-33. So if you can block some of these mediators and block this vicious path from initiating and proliferating and cause a vicious circle if you can somehow block one of these pathways, the asthmatic circle of doom with bronchospasm and everything else will be either less severe or may not be existent. Okay. So unlike your bronchodilators, unlike your inhaled corticosteroids, we're not now trying to treat the symptom. We're trying to prevent the symptom from occurring at all. We're trying to be proactive in the airways versus reactive by treating the symptom of asthma. We're trying to now control the pathway and the etiologies of asthma. So severe asthmatics have airway eosinophil persist despite administration of inhaled or oral steroids. There's no evidence of a reduction in exhaled nitric oxide, which is very important because, again, exhaled nitric oxide is a measurement used often to try to figure out if, one, there's inflammatory airways present, and what level of the inflammation is there. So often what will happen is if it's greater than 50 parts per million, the patient will be put on inhaled corticosteroids and then come back in 3 months, and you hope that that number is reduced. But in this group, despite being even on oral steroids, that number does not go down. The exhaled nitric oxide levels remain above 50 or higher, which say there's inflammation, apparent inflammation that's occurring. So again, in severe asthmatics, this group, there's no evidence of reduction of inflammatory mediators despite using the conventional type of anti-inflammatory agents. So that's why we have to start talking about biologicals. In the anti-G monoclonal antibody, okay, which is the most common, this is Xolair. The goal is to reduce free IgE levels in serum and inhibit the binding of Ig to the mast cells and basophils. So again, the old idea is you're going to try to prevent the release of mediators from the mast cell. Okay, and you can see that it is a pre-filled syringe, anywhere from 75 to 375 milligrams based on size, and you can, it's basically going to be, it can be administered by the patient, or it can be given in a clinic or in a provider's office. Okay, it's usually administered monthly. But Xolair, which has really been around the longest and was the earliest development as a biological for asthma, has been shown to be fairly effective in certain types of asthma and has been fairly safe. And here's the mechanism of Xolair, is that it blocks, here comes his free IgE, it blocks it. So it ends up preventing these mast cells from releasing these eosinophils, basophils, dendrite cells. So you don't have this exacerbation, okay? It reduces allergic inflammation, reduces mediator release, and improves the symptoms and complications associated with lots of medication use. All right. Now we're going to talk later that unfortunately, there's always a but when it comes to these medications. But here's the mechanism of asthma, of Xolair, in the sense that here comes the allergens that would cause the release, but because they were able to block this free IgE, then it decreased the chance of the mediators from being released. Very, very nifty idea. Again, not being reactive, being proactive. Now, there are other drugs out there. So this is mepolizumab, reslizumab, and bendozumab. Okay, these deplete the eosinophilic binding to the interleukin-5. So this reduces the alpha subunit of interleukin-5. Remember, we showed that earlier slide. All right, that, and this comes under the name of Nucala, which is 100 milligrams, and again, it's syringe delivered, is 100 milligrams monthly, 50% reduction in asthma, and there was evidence that there shows that there's increase in FEV1, which means that there's more airway patency and less expiratory obstruction, which is good. But again, this is an interleukin-5 receptor blocker, so this works different than Xolair in the sense that it's going to reduce the pathway of interleukin-5 and 5R. And again, you can see how this is going to work, okay? Again, we're going to give these medications. Interleukin-5 is going to be blocked, and thus it's blocked. It can't produce eosinophil proliferation, okay? So, and then here it's interleukin-5 is blocked over here, and 5A, 5RB. And again, all these blockers are blocking these cystotoxic mediators. So again, it prevents the activation and proliferation of eosinophils and the proliferate B cells, okay? And then on this side, it's kind of the same thing. So these are three different drugs that kind of, this one works here, the benarezumab, it works on blocking interleukin-5R, where these two over here do IL-5. But the idea is still the same. You're decreasing the amount of eosinophils, so you're going to decrease the number of mediators being released that were going to cause inflammation and thus the symptoms of the severe refractory asthmatic. Now, this one here is interleukin-5 receptor antibody. So this one here, Dupixent, is what you see this on TV. You'll see the lady jumping over puddles, and you'll see the guy diving into a pool and stuff like that. So this Dupixent, okay, it reduces the chance of and inhibits the signaling of interleukin-4 and 13. Okay, so with this, we're going to have reductions in exacerbations. There was a reduction in ER visits and hospitalization. So what's really nice about this is this doesn't seem to be just theoretical, garbage, in the sense that, well, we know that these drugs do this. These drugs actually do reduce exactly what we want in the severe asthmatic, reduce the exacerbations. They have a higher quality of life because they're not sick as much. They don't have to be on, miss work, miss school if they're children, and they don't need to, they get higher quality of life. Less ER visits and less hospitalizations. There's really no mortality benefit to these at this point because, again, asthma is such a low mortality disease, as I said, about 0.5%. Kind of, maybe over the years that data may, kind of fetter itself. But currently, it's really looking at ER visits and hospitalization. And all these drugs are doing very well when it comes to reducing, these refractory attacks that can be quite damaging to the quality of life. And just the way this works, okay, this works on the JAK inhibitors and reduces the T2 differential airway inflammation. So again, when you give the Dupixent, it increases the blood eosinophils and FeV2. So the idea here is that the blood eosinophils go up. That's the side effect of it. But the nitric oxide level goes down, which means there's less inflammation. There's increase in lung function, decrease in asthma exacerbation. The quality of life goes up. The FEV1 goes up. I'm not sure what ESI stands for, but quality of life, FEV1, upper inflammatory and upper airway patency, and also you look at decrease in T2 blockers. So you can see that there's a whole gamut of therapies out there when you come to biologicals that address all the different type of mediators. Again, this is IL-4, IL-13. So if you kind of block these things, then you don't have that inflammatory pathway leading to mediator release. And this is another one. This is an anti-epithelia cytokine antibody. So this one actually blocks interleukin 25 and 33 from the actual airway epithelial cells. So this actually blocks the release of leukotrienes that increase hypersecretions and can cause inflammation right in the epithelial cells of the asthmatic smooth cell. This is administered every 2 weeks at a 300 milligram injection. So this is the action of interleukin-3. You got their triggers up here, viruses and bacteria, smoke pollutant, or allergen. Here comes your dendrite cell again. And the idea is that this drug here is going to block interleukin-33, which would cause all kind of problems. So again, if you can, prevent smooth cell spasm, decrease mucus production, you can maintain. So again, this is attacking higher up on the cell wall, because this is in the actual epithelium of the actual bronchial wall. So again, this is interleukin-33 blocker. This is a nice slide, 2016, that ends up showing, again, this is how Dupixent works over here, blocking 13 and 4. This one here blocking 33. So it's kind of nifty that these microbiologists and physicians and really these people that are so smart have been able to figure out what exactly which leukotriene inhibitors are associated with these different autoimmune systems. Like, psoriasis has some that are different, lupus has something different, and then obviously asthma. So one can look at asthma as much as a external type of disease, it's kind of extrinsic asthma with triggers outside the body, as much as an intrinsic with the different type of reaction the body has to, it's like an autoimmune response. What's supposed to help actually hurts. So you look at this as the efficiency and safety of this, and you look at all these different studies, and really small percentage compared to the placebo. So with the placebo, 41% of the participants still had uncontrollable asthma. When you look at a single drug here, that this blocks again the IL-33. Very amount of people, only 22% had uncontrollable asthma. With here, they combined the two drugs, 27% had uncontrollable asthma. And when you look at Dupixent by itself, only 19%. So again, these were all fairly significant in improving the lower amount of under control, out of control asthma. Again, 41% with the placebo, it's almost 50%, where the interventions help tremendously. And this is, again, a very, very busy screen, but it looks at all the different biological disease, medications that can be administered by injection. Again, almost all of these are injections. Some are intravenous, but none of these drugs are orally administered. They're either subcutaneous, intermuscular, or they can be intravenously administered. And you can see when you have allergic asthma, type 2 high asthma, here's your allergens again, here's the eosinophils, your mast cells, and these different agents block these interleukins. Here's interleukin-4, here's interleukin 20, 33, 25. Now, by now, you should know interleukin-4, 5, 11, 5R, and 33, they're the big ones in asthma. And you can see here's the different drugs. Here's Dupixent, this is Xolair, And these are some of the other drugs I've talked about. The SC blocks interleukin 5, this 5R, these two block interleukin 5, Dupixent interleukin 4. So very, very interesting. And in low asthma, you don't really see the same kind of response that you do in the high asthma, which is allergic asthma, eosinophilic asthma. But this is a very nice, overall kind of capitulation of all the different biologicals that are available and how they actually work in a sense. And again, remember, Xolair has been around the longest, is an anti-AG, which prevents the mast cell from releasing all these different type of mediators there, leukotrienes, histamine, and interleukins 3, 4, 5, 9. But they're no good against, it's not, that doesn't deal with 33. So maybe in the future, some of these biologicals will be combined that can, direct, protection against all the different type of interleukins and mediators. And again, this is a biological agents. These are all approved by the FDA for severe asthma. It tells you what age group. So most of them are over the age of 6, over the age of 12, greater than 18, 12. So there's really no biologicals FDA approved for under the age of 6 at this point. And this tells you here, this is the drug. This is the route of administration. As I said, sub-Q, sub-Q. This is injection. This is IV. This is sub-Qs. So again, some of them are, auto injectors, so the patient can do it themselves. Others have to be done in a hospital environment, or not a hospital environment, but a provider environment, a clinic or an office or something like that. And this is like given every 4 weeks, every 2 to 4 weeks, every 4 weeks, every 2 weeks, and every 4 weeks. This one's first 3 weeks, followed by every 8 weeks. So there's different regimes and stuff like that. They all have safety concerns. We'll talk a little bit about that, but there's hypersensitivity reactions to these. You're more at risk for infections, things like herpes zosters, more likely to get sick, sore throat, colds. This has serum sickness, anaphylaxis, sore throat, back pain. But all of them reduce exacerbations, and all have been known to improve the quality of life. So that's a common thread. So choosing the initial biological therapy, so which drug are you going to use? You have to assess the number of yearly flare-ups. So do you really meet the definition? Does a patient meet the definition of severe asthma? Look at your biomarkers, the blood eosinophilic levels, your exhaled nitric oxide, what's the level of inflammation, serum IG levels. And again, that exhaled nitric oxide should be not used to diagnose asthma. It should be used to help assess and monitor the effectiveness of therapy with asthma. Your pulmonary function studies are still your gold standard. Look at FEV1s, quality of the life assessment, route of administration, subcutaneous or intravenous, when coexisting conditions. These should be all this should be assessed and, kind of regurgitated and evaluated to determine what is the best biological therapy for the, severe asthmatic. So again, when you look at your different choices, so when you're making a choice, you kind of look at, what's the indication, what's the age group, what's the onset, what do you allow allergic, what's the block, biomarker, what's the serum, what's the eosinophil, what's your exhaled nitric, coexisting conditions, and exacerbations. And based on this, will help you determine, should you really look at an anti-E antibody, look at this, 4R interleukin inhibitor or a 5R inhibitor. So again, if your age group is adults, you might want to look at the 5R as the onset, When you didn't have asthma as a child, but now you have it as an adult, you might want to look at 5-5R. You had it as a child, you might want to look at anti-E. So based on all these different, criteria, that's how your healthcare provider should be able to determine what is the best agent for the prospective patient. That's where we get into this heterogeneousness of asthma management, that we actually look at the patient with asthma as an individual and not clump them into a category of all asthmatics. Kind of drill down to specific therapy for specific type of asthma etiology. This is an example of a quality of life score. Ask questions, how many, in the last 4 weeks, how much time did your asthma keep you from getting to work, home, or school? And then you answer it all the time, all the way to none of the time. Did you have shortness of breath? Symptoms of asthma. How many times do you use your SABA, your rescue inhaler? How would you rate your asthma control? How did it limit your usual activities? Did it prevent you from doing things like housework, school, or social activities? Is it keeping you from socialization? There's a stigma of asthma. Very good presentation I heard one time at the AARC, that, asthmatics get stigmatized, and a lot of times they become social, isolation, because they're afraid to go out in certain environments because their asthma is going to kick up, or teenagers especially feel very conscious using inhalers or discus and things like that. And then for some males especially, it's a sign of weakness. Did it frustrate you? And then last, did you leave it too tired to do work and stuff? So this is like an asthma assessment that looks like quality of life. So when you initiate, you do this before the biological, you initiate the biological, then maybe 3 to 6 months later, you see if the quality of life has improved, along with looking at a FE and O levels and FEV1, PFTs. Another factors, again, is insurance coverage. These things are very, very expensive. So depending on your insurance coverage, or your insurance coverage may tell, they may dictate which biological you can actually use. The cost, patient preference, again, do you want to be able to administer yourself? How frequently do you have to administer it and stuff like that? And and self or healthcare personnel administration too. Okay, these are different things that are going to determine which biological agent would be most appropriate for a certain patient. Now, when you're monitoring the effectiveness of therapy, it's usually 4 to 6 month treatment assessment. So really assess anywhere from, a third of a year to a half a year. Review of assessment of symptoms and quality of life. Monitor use of oral steroid, because the idea is once you get in these biologicals, you shouldn't have exacerbations, which means you shouldn't have to use oral corticosteroids. What are the side effects? Again, we're going to talk about that in a minute or two. What's the patient compliance? The review of biomarkers, or eosinophil levels down? And then, how many times have you had to go to the doctor? How many times have you had to visit the ED? Hospitalization. Ideally, all these things should be reduced. If not, then we have to look at either the wrong biological agent has been shown to not work, or there might be other factors we have to reassess. Maybe the patient hasn't been totally truthful on not getting rid of the triggers, things. They still live in a very triggered environment, and or they're not using their daily medicines as controllers. Now remember, when you're using biological, that doesn't mean you still don't use your inhaled corticosteroids or your long-acting bronchodilators. You still need to use that therapy in conjunction with the biologicals. The biologicals do not take you off the maintenance therapy. They're an adjunct to the maintenance therapy, specialized for patients that have refractory severe asthma. So, the side effects of biological therapy, and, there's always a but, is injection irritation at injection site. There's almost all of these cause pain, swelling, irritation. Often one of the side effects is because we are blocking some of the body's natural responses to viruses and that. So we're actually asking the body not to be so protective because it's overprotective and causes a hyper response, as we say, is autoimmune response. These patients often have sore throats, nasal congestion, head colds, headaches, joint pains, sore throat, sinus infection, fatigue, conjunctivitis, and weakened ability to fight other infections. Before you start these, there should be a whole assessment, and there should be, TB test done. If you're sick, when you start these, you should not wait until you're feeling better. There's also the threat that vaccines do not work as effectively as they do in patients not taking these biological therapies. So one, they're very expensive, and two, there is a plethora of side effects. Again, you have to balance between asthmatics who can't breathe, someone who can't breathe, they can't go to work, versus the potential of these side effects. You have to balance out the benefit of therapy versus the side effects of therapy. Not always very easy to do in individuals that can't breathe or you're going to take being tired. Very, very difficult decisions to make sometimes. Cost of biologicals are incredibly expensive. So about $250,000 right now for these. Obviously, insurance reduces this, but right now, Xolair, looking at a patient that would get it basically every month, would pay about $81,000. Now, again, we're not patients aren't paying this for these biologicals, but they are very, very expensive at this point. And, it's that's one of the side effects of all biologicals. They can be very expensive. So they are not they're not really an option for individuals that don't have some form of insurance, or they're, independently wealthy at this point. So, the side effects and the cost of biologicals sometimes makes it not palatable for patients. So as I said before in the last slide, the balance between this is very, very important. So I think, when you're talking to your patients, you have to kind of talk about, as I say, the good, the bad, and the ugly when it comes to biological. It can increase the quality of life, but it's going to give you other, side effects and other potential physical issues, and the cost is fairly, fairly high. So, in conclusion, biological agents for asthma are efficacious and add-on therapies. Okay, remember, I kind of said this earlier, they do not replace your steroids. They do not replace, your inhaled corticosteroids or your long-acting bronchodilators, or maybe using stuff like Xolair as a leukotriene inhibitor also. It is a add-on therapy that can be very effective in severe asthmatics. If you have well-controlled asthmatics, you don't need to take a biological drug. It does show almost all the biologicals approved for asthma by the FDA definitely show that they significantly reduce exacerbations and improve the patient's quality of life. Most patients who do take it are willing to pay the cost if they can, obviously, and work, and take the side effects, which seem to be less than not being able to breathe at this point. We said there's a plethora of side effects associated with biological drugs. Biological drugs are very, very expensive. They're out of reach of a lot of individuals that are in the lower social economic group. And that's another whole story when we talk about the social economic impact of asthma. A lot of clinicians have said that is a more, asthma can be a social economic disease because people with low social economic abilities sometimes can, one, not afford drugs, and two, cannot get out of the environment that causes a lot of asthma triggers. And again, more head-to-head trials with these drugs need to be conducted to optimize patient outcome. We don't really have long-term data on the safety and, and long-term effectiveness of this. At this point, as a lot of, newer medications they come out, they seem to be, a panacea and as good as sliced bread, but then over a period of time, the data doesn't show that. So there'll be more outcome data on this, but right now, this seems to be an extremely energizing and new type of approach to the management of refractory asthma. So again, increase quality of life, increase the management of severe asthma. There's some good references out there. One of the best articles that I think you could read is Biological Therapies for Severe Asthma from New England Journal, from Bruselli and Kopman's article. There's another moderate to severe asthma from New England Journal of Medicine. And then this is biological severe, the role of a real world evidence from the registries from Genova in the European Respiratory Review. So these are nice adjuncts to this presentation. Again, you that manage asthmatics, I'll end this saying, please make it sure that asthmatics understand, even when they don't have symptoms, they still have asthma. Okay, thank you very much. And thank you for enjoying, I hope you enjoyed this presentation and good luck in your practice.